Good afternoon and welcome to today's Psychiatry Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, you may enter your question into the chat. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. David Mintz. Dr. Mintz is the Director of Psychiatric Education and Associate Director of Training at the Austen Riggs Center in Stockbridge, Massachusetts, a psychodynamic hospital specializing in the treatment of patients who are complex, comorbid, and treatment refractory. To address the treatment needs of these patients, Dr. Mintz and colleagues developed a psychodynamically informed, patient-centered model for addressing psychological and interpersonal interferences with the patient's healthy use of pharmacotherapy. His book, Psychodynamic Psychopharmacology, Caring for the Treatment-Resistant Patient, and dozens of other publications explores these principles. Dr. Mintz is also the recent past leader of the Psychotherapy Caucus of the American Psychiatric Association and is involved with many organizations that focus on psychotherapy, psychoanalysis, and psychiatric education. Join me in welcoming Dr. Mintz.
Hello, thank you very much. Thank you. So just maybe to start by saying that today we're going to take a look at the evidence base that connects meaning and medication, and in a way I would say the other evidence base, because for most of us, I think, who are committed to doing, when possible, evidence-based practice, often what that means in the field of psychiatry is matching a treatment, often a pharmacologic treatment, with a DSM diagnosis where it's been demonstrated to be effective. But there's this whole other evidence base, which gives us guidance not so much about what to prescribe, but rather how to prescribe in order to optimize outcomes for our patients. And we'll talk about how, I think at the end of this, you will have an appreciation, hopefully, for how much that meaning level contributes to treatment outcomes for the majority of our patients. And I'll just start by saying that medication outcomes really are shaped by a wide range of psychosocial factors which we'll go over. There are prescriber effects, characteristics of the pill make a difference, the setting of the administration, which is why we do, multi-center placebo-controlled trials and not just at one setting, because already in 1957, we were starting to understand that in one site, you might get a great result, and in another site, you'd get nothing. And so just where the medication is taken makes a difference. There are non-clinical patient characteristics, and by non-clinical, I'm really referring to characteristics that are more characteristics of the person rather than of the illness. And again, we'll go over this. And then factors like the therapeutic alliance, which shape outcomes. And to start, I just with one study to maybe drive this point home in a larger sense, that there was in the 90s a study, the Treatment of Depression Collaborative Research Project, which was before STAR-D the largest NIMH-funded multi-center placebo-controlled trial that had been done. And they were looking at the question of what's the best treatment for depression? Is it psychotherapy, either psychodynamic or cognitive behavioral, or is it medications? And what they found in that original study was all of those treatments were roughly equivalent in terms of outcomes, with the combination of medications and psychotherapy having a slight edge over any of those treatments as monomodal treatments. But sometime later, McKay, Amell, and Wampold went back and looked at that data through the lens of the prescriber. So they knew at each of the different sites who the prescribers were. And when they looked at it through the lens of the prescriber, it was very interesting, because it turned out that physician effects accounted for greater variability in outcomes than did medication condition. And when a prescriber got a good effect with a medication with a patient, they tended to get good effects with all their patients. And when a prescriber got a bad effect for the patient, they really tended to get poor results with all their patients. And then there were some people who were in the middle. And so using the statistical technique of linear hierarchical modeling, they were able to stratify the prescribers into those who are most effective, moderately effective, and relatively ineffective. And then when they looked at medication at the patients through that lens, it turned out that that patients that effects were additive. So that if you got a prescriber who was in the most effective group and the active antidepressant, you had the greatest reductions in depression. If you got a placebo and had a prescriber who was in the relatively ineffective group, you had the least reductions in depression. But, and I just want you to think about what I'm about to say, that the top third of psychiatrists in this large NIMH-funded study got better outcomes with placebo than the bottom third got with active drug. Okay, so just think about what that means in terms of how we sit with our patients and how powerful that is. And and of course, this is not like one doctor was seeing people for an hour and another doctor was seeing somebody for 15 minutes. This was an NIMH-funded study where the interaction was highly prescribed. So it was real subtleties that were making the difference between treatments that worked and treatments that didn't. And we really don't know what those top third of psychiatrists were doing, except maybe another arm of that study suggests that when psychiatrists had a psychological frame of reference, they maybe got better results than the psychiatrists who had a more biomedical frame of reference. So meaning is so important. And it leads us to the conclusion, as Michael Balint said in his classic book in 1958, the doctor in many ways is the drug. Like how we are there in the room with the patient is as important as anything else. But there are many things that contribute. The characteristics of the pill. So red pills versus blue pills, it makes a difference, right? Red pills, when it's red placebos versus blue placebos, red pills are energizing. Blue pills are calming in most cases, but not every case. Cataneo found that this result did not hold in Italy among Italian men, where blue pills were surprisingly energizing. And the hypothesis here is that, of course, Italy is a soccer-mad country, and the Italian soccer team is the Blues, right? So in the Western culture, for most of us, blue as a color, represents the color of tranquil seas and clear skies. But in Italy, it is a color that represents power and masculine vitality, right? So it has a very different effect. And there are many other things. So the route of administration, the more invasive, the bigger the results. So parenteral administration has of placebos has a bigger result than of oral administration. And we know also that expensive pills work better. So in the experiment, the placebo, you let slip, this is 25 cents or $75. And you could bet the $75 pill does work better. And this is not just academic, right? Because every day, our patients go to the pharmacy and they've been taking a big yellow pill for the last year or two, and then suddenly there's a little white pill, right? Because of generic substitution. And we know that most patients, more than half, will report decreased intention to continue their medications when they've experienced a generic substitution. It doesn't mean they stop, but they will tell you they're less likely to keep taking it. And 34% of patients experience new adverse events, which is either side effects or worse effects, less effectiveness. And probably most of that is not that there are substantial differences in bioavailability in those capsules. Probably a lot of that actually has to do with the experience of powerlessness that we'll talk about, causing patients to then have negative reactions. Placebo effects in psychiatry are, as we know, huge. On average, across drugs, the average effect size is about 1.05. And this is an increase over what it was 15 or 20 or 30 years ago. Placebo effects have been increasing, I think, as we move into an era where there's more and more faith in medications. So that, of course, is a problem now for pharmaceutical companies because they're having a harder and harder time differentiating actual clinical effects from placebo effects. And so that's harder to get their drugs approved. And in a meta-analysis that just came out 2 or 3 months ago, we know that like for major depressive disorder, the effect size is something like 1.4. For anxiety disorders, a little bit less. And at the bottom, effect size of placebo in schizophrenia is about 0.59, which is still substantial. And if you want to compare this to, the actual drug effects, so with antidepressants, active drug effects are something like 0.3 to 0.35, maybe a little more, a little less, but somewhere in there. So the placebo effect, the placebo component of that is at least 3 times, maybe 4 or 5 times what the actual drug effect is. And even with antipsychotics, where the effect sizes are 0.51, the placebo effect contributes about half of the benefit of that medication. And it's important to say that placebo does not mean imaginary. These are real effects, produce real clinical changes for our patients, real changes in brain chemistry. And they can really be lasting. So in a study by Kahn, Redding, and Brown in 2008, it looks like about 79% of placebo responders continued to be placebo responders 4 months out or 3 months out. And it was a little bit less, 93% of antidepressant responders were still responding, but it's still a substantial amount. And patients are not only helped by the meanings of medications, but many of our patients are also harmed, right? This is the phenomenon of the nocebo effect, which is the evil twin of the placebo effect, where expectations of harm are transformed into actual medical harm. And this can be explicit, like you're expecting harm, or it can be implicit or unconscious, as Jensen and Kapchuk found in a study where they unconsciously primed or non-consciously primed people to expect harm, and then they had an increased incidence of side effects. And who are the patients that experience this? We know that patients who have negative expectations at the outset of treatment are more likely to be harmed. Patients with high levels of neuroticism, where that expectation of harm or anxiety about that is just part of the neurotic makeup. And we know that patients who are primed to experience powerlessness are also more likely to experience harm. And so we know that there's a greater incidence of nocebo experiences in people from historically oppressed populations and people, which includes, racial and ethnic minority groups, as well as women and people of lower socioeconomic status. All of these people from all of these groups are more likely to have nocebo responses. And it's not only people who are disempowered from without, but people who disempower themselves also have higher incidence of nocebo responses. So, for example, people with high levels of characterologic acquiescence, the kind of patient who has to say yes, right? They go along. They're worried about what happens if they disagree. So it's almost like from within they're compelled to just go along and agree with what we want to do. And in these patients, it's almost as if they cannot say no with their mouths, so they end up saying no instead with their bodies. And the nocebo effects also raise complicated ethical questions for us, because another way that we increase nocebo responses is by telling people about the side effects that they could experience. And once we've told them about the side effects, they are more likely to experience those. But it is also unethical to not provide informed consent. And so we have a clash of, non-maleficence with, respect for autonomy in these situations. And maybe we'll talk about some ways that we can get out of that. Many, as I said, non-clinical patient variables affect medication outcomes. And as the cartoon says, I will pause for a moment so you can let this information sink in. There are many, many variables of patient temperament, patient's social positions, patient's expectations in psychology and their ambivalence, and all sorts of things will shape how medications work. And some of these we'll touch on. This really slide is just to overwhelm you a bit with the amount of, and this is just a portion of the data we have about non-clinical characteristics that influence medication outcomes. So we know temperament factors make a difference. So patients who are low novelty seeking and high in harm avoidance will have worse outcomes. This explains about a third of variance in treatment outcome, just that variable. Our neurotic patients, as we said, not only have higher levels of nocebo response, but they have poorer antidepressant response. Our patients with immature defenses are more likely to not respond to antidepressants, which makes sense. These are our, patients who are in cluster B or with, some kind of characterologic issues. So the, depression is just a small part of a big problem. Patients, interestingly, with an internal locus of control do better with medications than patients with an external locus of control. And similarly, autonomy versus sociotropy. Sociotropy is a variable defined by Aaron Beck. These are patients who are turned towards others, kind of anxious, maybe anxiously attached. They worry about is the relationship safe? Is it going to fall apart? They probably tend to be more acquiescent. And we know that patients who are low in sociotropy and high in autonomy will benefit from antidepressants about 3/4 of the time, whereas patients who are high in sociotropy and low in autonomy will only benefit about 1/3 of the time. As we said, our patients' attitudes affect outcomes. So when patients have high expectations, the vast majority of those patients will have some kind of response. And of course, a lot of that is probably a placebo boost to the medication we've prescribed, whereas patients with low expectations only will have about a 33% response rate. So these are patients, because of their low expectations, are getting no placebo boost to the antidepressant that we've prescribed. Or this study that I'm quoting is about antidepressants, but of course this applies to in different ways or in different amounts to probably all of our medications. We know that negative expectations promote nocebo responsiveness, and that patients' theories of illness make a difference too. And for patients who are mildly to moderately depressed, at least, they have better outcomes with antidepressants if they think that their depression is primarily psychological, situational, as opposed to biological. And we'll talk over the next couple of slides about the effects that a narrowly biomedical frame of reference has on the treatment and on our patients in various ways. Now, first of all, I think the field in various ways has been pushing a more biomedical theory of mental illness for the last couple decades. And this is not just because the drug companies are yanking us around and getting us to do that, but there are well-meaning campaigns, by the APA and the government intended to reduce stigma by promoting a biological theory. This is not a moral failing. This is something somebody can't control. It's just in their genes or their biology. But it turns out that backfires, because while there are some benefits in terms of increasing drug acceptance of drug treatment, and in some studies, there's evidence that it can reduce, biomedical theory can reduce self-blame, but not every study as we'll see in a minute. It turns out that in terms of social stigma, it actually exacerbates it, because it increases social distance. So if somebody holds a more biomedical theory of mental illness, they're going to be actually less likely or less willing to accept a mentally ill person into their family, their neighborhood, their place of work. And some of that is that there's an increased sense of dangerousness of people with mental illness. And I think the hypothesis is that because it is seen as something beyond somebody's control in their biology, we experience, if you have a biomedical theory, it's easier to experience somebody as unpredictable, dangerous, because they're not in charge of themselves. And those biomedical theories affect us as well. We know that the more, again, similarly, the more biogenic our theories are of mental illness, the less empathy we have. And this is across treatment conditions. So applies to schizophrenia, social phobia, depression, or OCD, and any of these things. And this effect holds for all clinicians, though maybe biggest for psychiatrists, or our scores end up lowest, largely because we actually start out with lower empathy scores, probably due to the brutality of our training and the dehumanizing aspects of it. And again, the hypothesis here is that the biogenic theory creates a sense of biological otherness where it then becomes harder to identify with somebody if you think of them, you think of yourself through a personal lens, but you think of others through a biomedical lens. And when we talk to our patients, when we share with them a more or less narrowly biogenic theory, this is a problem, you don't have enough serotonin, or, you have a gene for depression and that's why you're depressed. It turns out that actually has negative effects on our patients. In a study by Kemp, Lickel, and Deacon, where they took college students who had a history of depression, and they enrolled them in a study which was intended to determine whether the depression was a primarily psychological depression or a biological depression. So the experimenter comes in with a white coat, does a cheek swab, disappears for 15 minutes while they're running the test, and then comes back and informs these college students with a history of depression whether the depression seems like it's a genetically determined depression or more psychologically determined. And of course, this is a sham condition because we do not have that test. But for the students who were informed that they had a biogenic depression, first of all, in this study, they did not find that it reduced self-blame at all. And more importantly, it increased prognostic pessimism. So it's like, oh, well, this is in my genes. I'm never going to get over this. And we know that there is a direct relationship between prognostic expectancies and outcome. So as you lower people's prognostic hopefulness or expectancies, you are undermining their treatment, the good effects of your medication. Similarly, if for students who thought they had a biomedical depression or a biogenic depression, it worsened mood regulation expectancies. And we also know that negative mood regulation expectancies also affect treatment outcomes and coping behaviors, and directly affect depressed mood. And these patients also, patients had decreased self-efficacy in managing their depression. So the implication is, it's not that we don't include biology in our explanations, but that we provide explanations that help our patients retain some sense of power over their illness in a way that really grapples with the complex interaction of meaning and biology that we're going to spend this whole hour talking about. And we know that patients, like patients with secure attachment, we as psychiatrists, we probably don't see a lot of patients with secure attachment because these are the ones that get depressed. They see their primary care doctor, they take their medicine, they feel better, they never make it to a psychiatrist. So we see the more complicated patients, and we know that attachment styles have, play a real role, especially dismissive attachments. These are the patients that give up on us really easily, like, one strike and you're out. This is a study looking at diabetic control, but I suspect it generalizes to all of our patients, that patients with dismissive attachment are less likely to follow treatment recommendations, less likely to benefit. Their HbA1cs are higher. But it's really, maybe the reason I'm showing this is the important thing is there's an interactive effect with good communication. So if the patient rated their doctor as a good communicator, the adverse effects of that dismissive attachment style was negated. So you get a patient and you get a sense through your initial evaluation that this may be somebody with that kind of attachment style. You may say to yourself, okay, I need to be especially good. I mean, we should be good with communication with all of our patients, but this patient, you need to be especially good. And in terms of patients' attitudes, their ambivalence plays a role. And I suspect all of you have had patients. I know all of you have had patients who are ambivalent about medications, because probably almost every patient is ambivalent about medications. Everybody or almost everybody who's listening to me, if they had their choice, they wouldn't want to take medications, right? I don't. Doesn't mean I don't take medications, but I don't want to. If I didn't have something I had to take them for. So people are ambivalent about medications. And many of our patients are ambivalent even about getting better. Their ambivalence, it wasn't why they got sick or why they got depressed, but, as people do, you get a bunch of lemons and you start making lemonade. And our patients find the hidden benefits, and then suddenly they're in a dilemma, right? Because to give up their illness means giving up whatever those benefits are. And we know that ambivalence about medications is directly correlated with noncompliance. Patients who are ambivalent coming in are twice as likely to discontinue their medications and 3 times as likely to stop them if there's any kind of side effect at all. And we know that, also in terms of ambivalence, if you perceive there's something stigmatizing about medications, you're also less likely to continue taking them. And for patients who are ambivalent about illness, we know that patients with secondary gains are less likely to recover. And the patient's readiness to change makes a difference, right? And it's like the old joke, how many psychiatrists does it take? Only one, but the light bulb has to want to change. And that's true of our patients. That Beitman, for example, in his study of a benzodiazepine for panic disorder, as they were enrolling patients in this study, they also did the readiness to change battery from Prochaska and DiClemente. And so they could segregate the patients into those who were pre-contemplative, contemplative, and in action phase. And when they looked at pre-contemplative versus action phase patients, it turns out across this that the greatest determinant of outcome was readiness to change, outweighing the actual drug. So the patients who were ready to change and got the active benzodiazepine had the greatest reductions in panic. The patients who were not ready to change and got the placebo had the least reductions. But in those 2 other cells, right, the patients who were ready to change and got placebo had greater reductions in panic than patients who were not ready to change and got the active benzodiazepine. And similar findings have been found in the treatment of depression with adolescents. And so, the implications of this are, have to do with, well, how do we address the patient's readiness to change? Are we doing motivational interviewing with these patients? Are we using psychodynamic psychopharmacology to get at, or other techniques, cognitive behavioral techniques or whatever, to get at and start to nudge the patient's readiness to change? And ambivalence is everywhere. I mean, everywhere. If you are, as I am, a psychodynamic psychiatrist, you probably start from the position that everybody is ambivalent about everything pretty much all the time. And it's extremely common among our patients. So our patients are always, for example, mindful of how medications can harm them. In a study by Piguet, who was a medical anthropologist or sociologist, he interviewed people with a history of depression, something like 125, 130 people, something like that. And very wide open. Just tell us about your experience of taking antidepressants. And then they got these narratives, and then they did a factor analysis, and they identified 15 themes that tended to run across all of these narratives. And of those 15 themes, the top 4 were all about being harmed. It took to the 5th most common theme for patients to be talking about the way that antidepressants help them. So this is in our patients' minds, whether they're saying it or not. And we know that about half of patients also identify secondary gains from illness or from treatment seeking, which, then, amplifies their ambivalence. And we know that patients will not tell us they're ambivalent unless we ask. In a very wide open, interview where we're not asking specifically about ambivalence, only about 2%, 3% of patients will tell us they're reluctant to take the medications. When we ask now, a quarter to a third are telling us about the sources of their ambivalence. And then that gives us something that we can potentially work with, as opposed to the ambivalence just playing itself out more or less unconsciously. Pharmacotherapy alliance is another major factor. And first of all, alliance is not the same thing as compliance. Just patients doing what we say doesn't mean they're necessarily in alliance, because there's a whole unconscious thing that might be happening. Alliance really is a place where we meet the patient, somewhere in the middle optimally. And again, in another secondary analysis of the Treatment of Depression Collaborative Research Project, Krupnik-Sotsky et al. They had collected alliance data in this study, so they're able to look at outcomes also through the lens of the alliance. And they found that, the experimental hypothesis was, well, alliance is going to be super important for psychodynamic treatment, probably a little bit less important for cognitive behavioral treatment, and negligibly important for pharmacologic treatments. But it turned out the alliance was as powerful a factor in pharmacotherapy as it was in the psychotherapies, and other researchers have found the same thing. And that it was a stronger determinant of treatment outcome than a drug condition. So again, in this study, when a patient had a good alliance with their doctor and they got the active antidepressant, they had the greatest reductions in depression. When they had got the placebo and had a poor alliance with their doctor, they had the least reductions in depression. But again, in those two other cells, and you know where I'm headed, the patients who had a strong alliance with their doctor and got the placebo had greater reductions in depression than the patients who had a poor alliance with their doctor and got the active antidepressant. So again, the implication is we should be attending to the alliance, because that's one of the things that can make all the difference between whether a treatment works and a treatment doesn't work. And there's many elements to the alliance. I'm going to talk about a couple: warmth and presence, autonomy supports, agreement about targets, respect for treatment preferences, shared decision-making. We've already talked a little bit about good communication. In terms of warmth and presence, medication effects are shaped by the doctor's attitudes. So empathy, we've known this for 50 years, that our empathy contributes to treatment outcomes with medications, especially antidepressants, or at least that was the study that was done in 1973, where the empathic doctor just got better results. We know similarly that our investment in the patient and in their symptomatic improvement also makes a difference, promoting more positive outcomes. And our attitudes towards drug therapy, and this is a complicated one. So in the study, again, 70 years ago, almost 65, Uhlenhuth et al. Had doctors either model a kind of real optimism about medications versus, not so much optimism. And the more optimism the doctors had, the better the outcomes. Now, and I will say, I think, given the patient population I work with of treatment refractory patients, this is a thing that can kind of cut two ways, because it turns out this is probably a great strategy for a patient who's relatively treatment naive. If they've never had a treatment, or maybe have had one treatment, our optimism gives that medication a boost. But for patients who have already failed, multiple medication trials, and that, again, that's the majority of, or that's a lot of the patients that we are seeing as psychiatrists, because the primary care doctors are seeing the ones that respond, to one or two treatments. for the more complicated patients, when we are overly optimistic, they do not trust us. That undermines the alliance for these patients. And the risk being also that it disempowers the patients. Like they're just, if we're so optimistic, either they don't trust us or it puts them in a passive position where they are just waiting to be healed by us, right? Which is a terrible place from which to be trying to get better, and not having any sense of agency in your own recovery. Our warmth makes a difference. In this study by Cruz, where they just put a audio recording device in a psychiatric intake clinic. And one of the things that they were looking at was the tone, the intake clinician's tone of voice. And when that psychiatrist, and apparently it's pretty easy to judge when somebody has a warm tone of voice or not. There was pretty good inter-rater reliability on this. And what they found was when the psychiatrist had a warm tone of voice, there was patients came back, and for every standard deviation interval above the mean in warmth of tone of voice, there was a corresponding 162% increase in appointment adherence. So like basically tripled, right? The likelihood the patient was going to come back for a second appointment. And again, I don't know if and how we teach our trainees or ourselves to have a warm tone of voice, but it is one of the things that we can work on that increases the likelihood our patients will come back. Similarly, Rosen, Nakash, and Allegria did a study where they put a video recording device in the intake clinic, and they were looking at whether or not the clinician interacted with the computer. If the psychiatrist touched the computer once, even once, in the patient's presence, that was coded as a session with technology interaction. And when the doctor was touching the computer, first of all, they measured alliance, and it significantly lowered the alliance. But second, it reduced treatment continuation. So if you didn't touch the computer, about 77% of those patients returned for a second appointment. And when they touched the computer, only about a quarter of those patients came back for a second appointment. Now, I don't know what to do with this because this is probably not your experience, because the whole field has moved towards typing on the computer while you're talking to the patient. And we probably have developed ways of apologizing for it or really working at making eye contact or some way to ameliorate those effects. And but it does seem likely that even if the effects are not as big as this, that anytime we interact with the computer, it is having some undermining effects on outcome with those patients or treatment continuation. One of the other more powerful things that we can do is figure out what patients our treatment, what treatments our patients want. And we know that patients receiving their preferred treatment modality do better. So in the study by Coxus, they enrolled patients in an antidepressant study. They assessed, what treatment do you want? Do you want medications or do you want psychotherapy? And then they randomized them. And when patients were randomized into their preferred treatment, about half of those patients had a meaningful response to that treatment. So had substantial reduction in depression. When patients who wanted psychotherapy, who wanted pharmacotherapy, antidepressant medication, were given psychotherapy, only about a quarter of those patients benefited. And when patients wanted psychotherapy, but were given antidepressants instead, only 7.7% of those patients had a clinical response to that antidepressant treatment. So, it's best if we're not in that position where if all you have is a hammer, everything looks like a nail, where we really are assessing our patients' treatment preferences and where possible, trying to steer them into rational treatments that they prefer. And we know when patients get the treatments they prefer, they respond more rapidly. And one concern is, well, I don't have the time to figure out what patients want, but at least in a primary care setting, the work of doing that does not, and these are settings where the appointments, of course, accordion quite a bit in terms of complexity of that interaction. It does not seem like it adds any time onto the consultation. Also, we know that when patients are given a non-preferred treatment, they're more likely to discontinue treatment and more likely to miss follow-ups. And, in terms of just social justice issues, statistically, people from marginalized communities are more likely to prefer counseling over medications. But we know that for these, marginalized populations, at the same time, we tend to give them less information about treatment options. We steer them more towards the ones we want them to have. And we communicate in ways that perpetuate patient passivity. And if you were listening to the rest of the stuff, which leans into things like powerlessness and, ways that our unconscious biases really undermine treatments for the patients who are already most subject to negative effects from systemic biases. And so, so for those patients, but all patients, it really is important to involve our patients in medical decision-making. And we know in this study by Woolley et al. At the Institute of Living, they took patients who had been hospitalized with suicidal depression. And I think they were all put on probably escitalopram, but they were given a choice. Do you want to take this medication once a day or 3 times a day? Obviously that's from a clinical perspective, that is a meaningless choice. It makes no difference in and of itself whether the patient is taking it once a day or 3 times a day. But the fact that they were given a choice, just that choice, increased the likelihood that they were still going to be taking that antidepressant. I forget whether it's 4 or 6 months out. It increased it almost 2.5 times. And if the patient was in agreement with their diagnosis, it increased the likelihood the patient was still going to be taking that medication several months out 7.3-fold. Okay. And of course, we are constantly making treatment recommendations where there are many viable options, right? And if you're going to prescribe an antipsychotic or an antidepressant, an SSRI, there's, the differences between our SSRIs are so small, and really in terms of clinical benefit, almost non-existent. The main differences are, more about side effects and things. So anytime we're offering a patient a medication, probably makes sense to offer, to give them 3 different medication offers or, something like that gives them some buy-in to one of those treatments. And, some patients will be like, how am I supposed to know? You're the doctor. And, then you can make a more specific recommendation. But really, I think important where possible to give our patients choices about the kinds of treatments we're going to be offering. And when we involve patients in shared decision-making, these patients not only are taking their medications still, 4 to 6 months out, but they have improved outcomes 18 months out. And, one objection is, well, I can't ask my patient what they want because, we're going to end up with all sorts of crazy things because, they're not a doctor. But it turns out when you involve patients in shared decision-making, you get treatments that are actually more consistent with published guidelines, not less. And so just in summary, well, good, we'll have 15 minutes or so for questions. You really can't reduce psychiatric treatments to either the biological or psychological domain. The patient is taking a medication, and that medication is as symbolically powerful, if not more so, than it is biologically powerful. non-pharmacologic variables shape pharmacologic treatment response. And a large proportion of medication response is attributable to these psychosocial factors. And I'm going to make a provocative argument here that because of how powerful the meaning dimension is of pharmacotherapy and all these, I mean, these studies were just a tiny fraction of the studies we have out there that give us guidance about how to prescribe. If we are only paying attention to the biomedical evidence base and neglecting this psychosocial evidence base that I've spent the last 45 minutes talking about, I think we're really not doing evidence-based care. It is that important. And so that's a question that we have to ask ourselves is are we really doing evidence-based care if we're neglecting that? And, I think the other implication is given what the evidence suggests about how powerful it is, we should be teaching it more in residencies. We should be doing more research on that. Of course, like our doc, 20 years ago, 15, 16 years ago, the NIMH decided they're only going to research things with identifiable biomedical targets. And, Tom Insel, who ran the NIMH, ended up concluding that for all the billions of dollars that they spent, they did not, as he said, move the needle 1 inch in improving the lives of the patients we're treating. Now, hopefully, 10 years out, 20 years out, 50 years out, the things we were finding will benefit our patients. But I think if we were putting money into studies that helped us know how to prescribe better, we would be improving the lives of our patients tomorrow. And so with that, I think we're ready for discussion.
Okay, thank you, Dr. Mintz. If you have a question and you're viewing online, please enter in the chat section and we'll ask the question for you. I'll open up questions here in the audience.
Dr. Mintz, I'm Joseph Fowler, one of the PGY3 psychiatry residents here. Thanks for presenting. I had a question specific to genetic testing, kind of two thoughts on it. It would seem to overemphasize the biomedical model, but at the same time, I've often seen patients bring it in and it leads to like a more collaborative ability for them to use autonomy to choose medication practices. What are your thoughts on it?
Well, my first thought is that my understanding is the guidance from our governing agencies is that they're not quite ready for prime time yet. So should be used with caution, or at least we shouldn't be too overly optimistic about the guidance they give us. But to your point, my microphone just cut out.
I think you went mute on us for just a second.
Okay, am I back? Hold on. Yes.
Yes.
That it has to do with how we talk to our patients about it. Like, I don't think we should be asserting at all that there are no genetic components to this. But to talk to patients about this as if it is only biological or only psychological, either form of reductionism, I think, has the potential for negative effects on our patients. And, we know, and it's complicated, like with the short serotonin transporter allele. Caspi discovered 15 years ago or so that, if you have that short transporter allele, you may be more vulnerable to depression. So we thought we had discovered a depression vulnerability gene. But then they discover, no, it's not that, because it is only depression vulnerability gene if you have a degree of childhood adversity. So it's more like it's an environmental sensitivity gene that predisposes people to depression if they have bad, difficult early experiences. And then they discover, well, actually, and if you don't have bad early experiences, then what it does is it actually confers a benefit to you. Because if you have this short transporter allele and you have an enriched early environment, you're more creative, you're more sensitive in a way that benefits you rather than hurts you. And so that kind of complexity, I think, is how we want to engage our patients, is whatever the genetics are, with my patients, I'm sometimes having that discussion of how do we want to try to turn your sensitivity into something that benefits you. And to the extent that it is, like you said, it maybe gives some guidance to a patient where they feel like they are maybe able to collaborate in a way that makes them more of an agent in their treatment. Well, yes, I think I'll take that medication because, I'm, kind of a slow metabolizer and, 2D6 or whatever. And, to the extent that it increases the sense of patient empowerment without doing something that also disempowers the patient, it's probably not a bad way to go about it. And again, some of that hinges on how we talk to our patients about the complexity of that.
Okay, one more question here.
Hi, I'm Haley Silverstein. I'm a second-year psychiatry resident here. I was wondering what your thoughts are, since telehealth became such a thing with COVID and doesn't seem to be dying down, and now people can get medications for depression, ADHD without talking to anyone, just online through a website. And it seems like you stress the importance of the relationship and nature of that with the patient, and how you think either there are some benefits to this move towards more distance treatment and therapy, versus if do you think there would be any harm with it or less compliance?
So, well, I mean, I will say certainly it seems to be the case among psychodynamic psychiatrists that there's a lot of anxiety about this, that there's a feeling that not being in the room together really undermines treatments. And that's not necessarily what at least in terms of psychotherapy, that's not what the evidence shows, that as long as you're face-to-face on a computer screen, it does not seem at this point to be really undercutting treatment outcomes. Now, you painted a more of a picture of something where there's almost like you're filling out a questionnaire and some doctor says, oh yeah, you can have an antidepressant without almost any, person-to-person interaction. And again, this hasn't been studied as far as I know, but my guess would be, given what we know about the power of the alliance, that probably is having some negative effects and things like treatment continuation. But, we as far as I know, there's not data on that yet.
Oh, we've got one. Give me 1 second, walk across the room.
Thank you. Hi, Dr. Mintz. My name is Sam Dotson. I'm one of the faculty here in the outpatient setting. And I was curious if you could provide some input on what it looks like practically for you when you're talking to patients to implement two of the strategies that you discussed. Like, what are the phrases that you use, or how do you actually bring up these topics?
Yeah.
One is exploring ambivalence around medications, and the other is balancing the informed consent process with the risk of inducing negative expectations in the patient.
Yeah. So on the first, I mean, the way I work, and I have a model that we've developed at Regs that we, was mentioned in the intro. And this is not the way the world works. Like, I feel like it's important to do a 2-hour intake. And I think the field should be doing it, and we're not, because I want to know who the patient is first and what the patient is second, and what in terms of their diagnosis. Because I treat a patient population that is almost exclusively complex and comorbid and treatment resistant, and they've already failed a million things. And so I really want to know why, what is it about that patient that makes them treatment resistant? So in that first session, it's all about trying to understand the patient's relationship to pharmacotherapy, the patient's relationship to treatment, patient's relationship to caregiving. And then after that, a half hour once a month, every couple of months seems adequate. But I think we really need to have a better understanding what's going on with their patients in the up front. Now, some of the questions, so some of the ways that would go would be, I ask a patient, first of all, I start from a developmental framework, like, where are you trying to get in your life and how are your symptoms getting in the way, as opposed to a more narrowly symptom-focused approach, which already pushes it kind of into, for me, a more dehumanizing kind of engagement. So we start with that. And then as we talk about symptoms, at some point I will ask, well, how far back does that go? Like, when did you first, really start to find you were struggling in some way? And for the patients I treat, almost always that's going to be somewhere between the ages of 3 and like 14. Very few of my patients were fully psychologically healthy until they became adults. And then that question leads to a question about, well, what was going on back then? And then again, much of the time, then they're telling me about something in their childhood, their authoritarian father, their parents' divorce, their mother's, alcoholism, the neglect. People were really busy with their jobs, and it was chaos at home or whatever. And then that leads to the next question, which is, so how does that influence how you relate to authority figures and caregiving figures? And right away, like half the time, patients tell me, "Oh yeah, I really don't do well with authority," or they're telling you about their potential negative transferences to caregiving authority, which we can then mark and say, "Oh, so we should pay attention to this because this is the kind of thing that could interfere with your treatments working as well as they might." So that's a way of identifying ambivalence about treaters. And then, a question about identifying ambivalence about medications. Simple, right? This is something that takes a minute. What's it like for you to take medications? And patients will tell you that, I don't like to take a medication. Well, why not? Well, I don't like to be dependent on anything, or if the medications do it, it doesn't mean I could do it myself, or something. And so, and again, then we can highlight, because I'm trying to do this with my patients, to highlight in the beginning how much meaning factors play a role, so that we can then address those later on when they come up. And in terms of ambivalence about getting better, I will also ask, is there anything you might stand to lose if this treatment works? And, maybe 2/3 of the time, patients will not have a clear idea, but 1/3 of the time, they will tell you why they don't want to get better. If I'll lose the attention of my husband. I will, if, a young patient that I treated who was a trans man, said basically, if I get better, it means that all that crap I went through and all the injustice I faced didn't matter. So he was he had in a way turned himself into a living monument to the injustices he experienced. And so, patients will lay that out. In terms of, so those are just some of the questions. I will say that's a question you have to ask in the first or second session. Because if you wait till the patient is like, you're in some kind of fight and the patient's not getting better, and now you ask, well, what is it you stand to lose if you get better? The patient gets defensive, and they get defensive for a reason, because when you asked it in the first session, you were curious. When you ask it, 4 months down the road, now you're blaming or judging. In terms of the nocebo thing, there are different ways to do that, but I want my patients, I give them a lecture about the nocebo response, and if somebody has a lot of side effects, or placebo response, and if they have a lot of side effects, the nocebo response, and the importance of the alliance and factors like this. And around the nocebo response, it might be, it certainly would suggest that a strong alliance protects against that, so we might want to pay a lot of attention to the alliance. Somebody I might say, it is the case that if I tell you the side effects of this medication, you're more likely to have them. And so we should maybe discuss how much you want me to tell you about what you might experience. Now, of course, if it's something that the patient absolutely needs to know, like, Lamictal rash or something, you educate them about that, whether they want it or not, because you need to know if they're starting to get an early rash. But for many other things, headaches and all that stuff, you might want to give a patient a choice about that. And again, as we said, giving patients choices plays, an important role. And also just educating patients about nocebo responses seems to lessen nocebo responses, or at least gives you a way of stepping back and questioning, is this real? Is this my mind doing this? And I will say lastly, though, while there is evidence that suggests if you tell people about side effects, they're more likely to get them, there's also evidence that shows that if you have told them about the side effects, they are more likely to keep taking that medication in the presence of side effects rather than a side effect that popped up that they weren't expecting or hadn't been discussed. So it's a bit of a double-edged sword. And I think with that, we're probably at time.
Oh, one more comment here from Dr. Prasad.
Dr. Mintz, I just wanted to thank you for a wonderful topic. All of us needed to hear it, especially the residents. And I just wanted to give you credit for doing all this research. We all know it, but to hear it within 45 minutes of the great summary you've done in this talk, I just wanted to thank you very much for it.
Oh, you're very welcome. It's been my pleasure. That's, this is, probably you can tell, it seems so important to me that we as psychiatrists have some kind of biopsychosocial balance in the way we approach our patients, because again, makes all the difference between treatments that work and ones that don't. So I thank you as well for the opportunity to share this.
Thank you, Dr. Mintz. Great presentation.